So welcome to the DrDoctor podcast. I'm Tom Witcher. I'm the CEO and founder of DrDoctor, and we're here today to talk about digital mental health with the team from Oxleas. Right now, it's about how do we create that behavioural and cultural change. And I'm particularly interested in mental health and also in community organisations. We tend to find rolling out tools like digital letters takes longer. It's more complicated. I think possibly there's more smaller services that have more independence. I'd just be really interested to hear your thoughts on the cultural change and behavioural change from the staff and internal side as well. What can we do in complex organisations to make the rollout happen more quickly? And is my assumption right there?
I think that's probably a fair assumption. I think when we were talking with partner trusts, so Lewisham and Greenwich and Acute Trust that we work with quite closely, they were saying that their adoption rates were 70% from the start. And I think we just went into this assuming that we would be the same. Yeah. But what we found is that our staff make assumptions sometimes on behalf of their patients. So the team were giving me an anecdote the other day about our frailty team and some of the staff making assumptions that patients wouldn't want to receive letters digitally, and also making some assumptions that DNA rates had gone up because of DrDoctor. Now, when we unpicked it, we found that wasn't the case. But people make assumptions, but they also perhaps drive, in this particular case, the delivery of letters based on their own preferences. So if the staff member decides, staff members may, for very good reason, think, actually, I'm not certain these patients want to receive these letters digitally, they will make that decision on their behalf, and the letters will not even go to Oxcare. And so, again, it's unpicking that, understanding the reasons why we're not sending out these letters digitally by default, and then understanding whether there are valid reasons. And we have heard some valid reasons from some of our staff that, again, we're trying to unpick and see whether or not we can sort out those issues in different ways. But I think it's getting into that detail and really understanding what's going on.
There's an interesting mindset shift there, isn't there? From I'm going to decide whether or not this patient is appropriate for digital letter to then letting the patient decide. How does that play into that personalisation narrative? And is that a fair challenge from those staff, or do we need to let go? Do we need to give patients more agency? And
I think it's really interesting in terms of we could certainly get into a conversation about. There's been a lot of talk about patient-centered care for sort of a good probably a decade or more, and I still think there's a sort of a relatively the doctor's right that if the doctor decides you don't want you're not ready for a letter digitally, then that's what the doctor's decided, or there are other clinicians available. But there is that sense of we're so used to clinicians making decisions on behalf of patients, and I do think one of the challenges, and it goes back to the conversation I was having around messaging, is the shift of power to patients really challenges some of the clinical team's ability to safeguard themselves. Right. Yeah. So one of the things we have to reflect on one of the barriers around culture is clinical teams generally feel overwhelmed quite a lot of the time, and they're there to protect themselves. And in a way, as an organization, we have to kind of acknowledge that, because if we don't protect our clinical teams, we're not going to have any clinical teams because they'll all leave, right? Totally. So we've got this fine balance between acknowledging that fear that we're going to be overwhelmed. If people start interacting with us digitally, I don't really understand that as a clinician because I'm not that digitally confident, but also it's additive rather than, adds workload to me rather than takes workload away from me. And I think we've got this difficult period where we have to kind of get through that to get to the other side, where we have got empowered patients who have the tools that mean that they can interact with us differently, and we can then as clinicians feel the benefit of that. But it's this kind of, we've got to as clinicians, I think the challenge is letting go enough to get through that period to then get to a point where actually everyone's benefiting.
Getting over that activation energy is a huge thing. And it's really interesting hearing you talk about that, because one of our big focuses in the acute world is moving follow-up appointments from being time-based to data-based. So rather than booking your follow-ups at 3 months or 6 months, you use a remote monitoring form, and based on what that form says, you bring the person back, which I'm sure has very directly applicable in your case too. But you do have this huge challenge of, in the short term, you create more work.
Yeah.
Because you have to review those forms.
Yeah.
And reviewing those forms takes time. So then you have to find a way of creating, you know, a PA a week or whatever it is for people to review the forms. But you've got to do both things for a while. And that is a huge problem. The nice thing is when you come out the back end of that, you're only bringing into clinic the people who really need you, and you're having these really high value, top of your practice conversations all the time. But there's an activation energy. And if you're not yourself a sort of digital evangelist, it's really, really, really difficult to bring people on that journey.
Yeah. I think one thing, let's reflect on, looking, you know, we've kind of given you an idea of the story over the last 10 years around patient engagement platforms and that kind of digital health technology. Clinical leadership is absolutely key. Where we've seen uptake is where we've seen that clinical leadership. In my own team, it was, I mentioned Nicola and myself driving that. Without us, it wouldn't have happened.
Yeah.
If we look at the other teams where we've had that successful adoption, it's because there's been senior clinical leadership going, yes, we are going to do this. And we're going to tolerate that double running for a bit, but also then acknowledge like we're going to have to shift the way that we work. And, you know, some of it's about, for example, if somebody phones in and says, when's my appointment? It's the person who answers the phone saying, hey, have you got your DrDoctor account? Can you log back into that and check next time? Let's do it with you on the phone, right? Because if you just tell them next time log in, they're not going to do it. If you go, right, we'll do this now with you. Let's just spend a bit of time on the phone, logging you in. Can you see your appointment? Great. They've done it once. It's that muscle memory. They've done it once. Now, next time you can do it again. You've saved yourself like 10 phone calls in the future when that patient now realizes they can log on to DrDoctor and see their appointment. Yeah. And those are the things where I think it's not just our clinicians, it's our admin team invested in putting that 2-3 extra minutes in place in order to then pay it back to ourselves in the future. Yeah. So yeah.
And everybody has to be behind that, right?
Yeah.
Everybody has to be behind that. And it's really interesting. So I used to give a talk at conferences which was called Gentle Disruption. And this talk was about you get organizations to change by doing small iterative changes. You do little things bit by bit, and before the organization knows it, it's actually done quite a big change. I think the problem we've just talked about here, it doesn't work if you do it that way, because actually what you're doing is you're asking a whole organization to work differently. And that's really, really tricky, right? It's fine with the letters and the base of the pyramid we talked about. Yeah. But when you start getting into we're going to change the clinical model here, it's a different conversation. Like how ready do we think the NHS is for that more broadly? Are we now at the tipping point where people are ready to have that more disruptive conversation, or is there still quite a lot of work to do getting the basics in place?
So I think there is perhaps a readiness now, but I think that cultural change and shift to using technology more in practice is still really tricky. Yeah. I know in our organisation, you know, with the 10-year health plan, the real focus on moving from analogue to digital, we're having a lot more conversations than we used to, and we're starting to think about how we can change models of care. So with our adult community mental health teams, James and some colleagues in our directorate, we're looking at their pathway recently, understanding how it currently works, and then starting to think about how we could have digital pathways in the future. And that's certainly a conversation I don't think we probably even would have had 2 years ago. So I think there's certainly an appetite to think differently. And obviously, you know, as I mentioned with the letters, there's some savings to be made. Yes. If you can shift people to exactly similar service, but if you take the digital version, it's a little bit cheaper. Yeah. And in the case of letters, quite a lot cheaper. So I think there is appetite to consider how things could work differently, but we need to invest properly in that cultural change and supporting that change to enable that to land properly. And
it's really exciting to hear you guys talk about that so coherently. It feels like something that Oxleas is good at, or at least it's high on the agenda, which it isn't in lots of places. To be honest, a lot of organisations are still viewing this as a technical problem. Yeah, and really,
and it absolutely isn't. Yeah, I mean the technology is the easy bit, right? It's that cultural change and kind of how you design your pathways that really will make the difference.
Yeah. What levers have we got, like collectively, and also kind of as a system to help with that cultural change? Because so much of it is about a lot of it's about boots on the ground, right? I'm a huge believer in get really close to the problem, and that's the way that you build trust and change. But there's also kind of the bigger levers. Is there like an ecosystem play here? Should we be working together to get out the message that this is happening and it's just a case of when?
I think there are some national things that are happening, right? So, you've seen with some of the funding that's coming through for the NHS app, and that's certainly helping with adoption. We've been lucky enough to receive some money to enable us to connect hopefully up with the NHS app. So I think, there probably are some national levers in kind of making that step change to making some of those national initiatives happen quickly. And I think, but I think locally as well, there's lots that can be done within organisations just to think differently. And as I said earlier, just thinking about pathways, getting a multidisciplinary team together to understand, what the problem is, how we can change the way that pathways work, and just everyone having their input really makes a difference.
Yeah, it does.
I think there's definitely a number of, in terms of the ecosystem, certainly from an Oxleas point of view, we've got a number of interrelated platforms and processes. So, for example, thinking about outcome measure collection, we've got in our CYP, so Children and Young People's Mental Health Services, we've got an outcome collection platform. We've got Luminova, which is a clinical CBT-based game for anxiety, children with anxiety, sort of 9 to 12-year-olds. And so that we've got an outcomes collection platform. We've got a digital therapeutics. We've got Thalamos, our e-mental health app platform. Yeah. We've got Universal Care platform in London, which is a platform that they've invested in London, which allows us to share care planning. Now, I think the challenge we've got as a trust is how, and I suppose regionally particularly, is how do we integrate and interface these different systems. So we've got London Care Record as well, which is a clinician-facing sort of platform that shares, that has information from different healthcare organisations in South East London, but also from wider in London as well. So as a clinician, I can log on to the London Care Record and see what's been going on for that patient in other. I can see blood test results. I can see clinic letters from Guy's and King's and St Thomas's. How do we put all of this together? How do we put all of these different systems to create that really good user journey? So for the patient, that's about not having to repeatedly enter the same information into multiple different systems. It's about being able to see all of your care in one place. So, I hear from a few patients who are open to multiple services, not within Oxleas, but within sort of Southeast London, they often get appointments on the same day. And like, how am I supposed to get from Guy's to Oxleas? Right, and like the they have to cancel one appointment. Like, how could we not coordinate that a bit better, right? If we could see each other's appointments, well, there's no point in booking an appointment in Guy's for this patient because they've already got an appointment in Bromley in Oxleas. So, and I think that will then, support the patient, support productivity, because we'll get less DNAs that have to deal with less cancellations. From a staff point of view, it's about being able to see all of that information, being able to access all of that information easily. One of the things that staff complain about, and you'll hear this from other trusts, is, having to log into different systems. Yes. Like, I've got to log into this system and that system and that system and this system. How do we create that kind of centralized kind of ability to log into all of these systems? How do we create that integrated interface so you can look at, so for example, with a patient engagement platform point of view, how do we surface the results of those questionnaires that a patient might have filled in alongside the clinical information in a way that enables that clinical thought process to happen easily?
And there's a number of things I'm absolutely fascinated in what you've just said. I actually gave an interview recently about digital health in the UK, and I said integration isn't the problem anymore. It's much more about where the information is surfaced. Do you think that's true? I feel like 10 years ago, integration between systems was a real challenge, and we've made huge progress there. Is that fair?
I think yes and no. I mean, I think certainly for patients, it feels like, if everything could be surfaced within the NHS app, it doesn't matter where that information is stored. So, certainly from a patient perspective, I think from a staff perspective, there are still challenges. And we need to be better at surfacing information from different organisations to help our staff manage care in a more joined up way. I think we've made good inroads. London Care Records are a really good example. We've got key information in there to enable certainly clinicians in our trust, they can access it, London Care Records through our clinical system seamlessly, which means that they have key information available. But we know that in some areas, and particularly in physical health, actually having more detailed information from the GP record would be really helpful. Now that we're starting to think about how we connect up within neighbourhoods, we're starting to think about how we can provide more detailed information to our staff and to staff who work within the borough, kind of providing that overview, that kind of user interface over all the different systems that sit below within a borough, so Bexley or Greenwich, where we're going to be the integrators.
Neighbourhoods isn't going to work unless we solve this problem.
Absolutely.
It really isn't, and it's thorny indeed. I think the really interesting thing about the shared care records that exist at the moment is they tend to be read-only. So they're a view on the information, and a view on the information is great and is much better than not having it at all, but there's very little opportunity to transact on it and write back and action it. And I think for that vision to succeed, we've got to find a way of making these things transactional systems. On the point of logins, because I'm really fascinated by the clinician login thing, because everywhere you go, the first challenge you get is not one more system to log into. I'm absolutely refusing. I've literally watched people walk out of a room over logins. I'm sure you have too over the years. I have quite a strongly held view that we can make it easier for people in lots of ways. But if you make a user interface which is genuinely better and genuinely value adding, that tends to fall away. People log in and they realise that this application is providing me value in my day to day. Because in our organisation, which is a tech business, I log into 20 systems. We have Jira, we have Slack, we have Outlook, we have Gather, we have Miro, we have Notion, we have and a multitude of others, PostHog, all of the different HubSpot, and I log into them all every day, and they all add value to me every day. And I don't mind. I don't really think about it. I'm like, okay, cool. And so I have this it's a very personal view, because I've never been a clinician getting frustrated on a night shift, not being able to log in, to be fair, that as long as the user interface is good and the application's adding value, people don't mind. Am I right? Or have I missed a trick?
So I think what you've picked up there is a really important, which goes back to culture, which is clinicians come a lot, and this is kind of broad brushing clinicians in a kind of whatever, but there is still this sense that technology is getting in the way of us doing our job, right? Yeah. So any grit in the system, any sort of friction feels, like the sand in your shoe, when you've been on the beach, right? That kind of sense of just, it's there, and it's just going to make your job much harder, because the job that people trained to do was sit down and talk to people and help people. And that sense is the technology just gets in the way. Whereas I think if you're coming from a cult, like a digital organization where the assumption is the technology's helping you do your job. All of those platforms you do, like the reason they add value. And I think that's the thing. Clinicians don't see technology as adding value a lot of the time. It's just something they're made to do.
It's more process. And
I honestly think a lot of our clinicians would quite happily write stuff on, go back to paper records, right? I honestly think if they were given a choice, quite a lot of them would. And actually what a lot of them do is write their notes on paper when they're with the patient, and then they have to go away and type them up.
Interesting.
So you're separating out the act of care from the administrative act. Right? And I think there is a real challenge around how we change people's perception. I don't think people realize if they acknowledge they're technology dependent, it's with a sense of frustration that they really don't want to. Yeah. And I think some of the login issues is like a shortcut for saying no,
Yes.
right? It becomes the yes
Yes.
but, right? Yes, but I have to sign into another system and I don't have time for that. So, yeah.
That is
But I think London Care Records are a really good example. So initially we had a separate login.
Yeah.
Staff had to log in separately to London
Yeah.
Care Record. And there's a really, great information within the London Care Record, really useful for patient care. Not many staff logged in.
Yeah.
The minute we put it within the clinical record with a hyperlink and they didn't have to log in again, we just saw the uptake just soar, didn't we? And I think just making that a little bit easier for staff meant that it was much easier for them to get the information. Therefore, they went to that information.
And I think one of the things to reflect on there is when London Care Record first went live, you had to indicate that you had got consent from the patient to access London Care Record. Right. So it was an extra. Now, one of my reflections is staff don't like to do things wrong, but they will choose the least wrong thing in their mind rather than, so for example, one of the barriers to sending letters at the moment digitally is where staff are not sure that the details on the system are correct. Right.
Yeah.
So they would rather send it via a paper letter than get it wrong and send it to the wrong person, because then they'll have to fill in a DATEX form and to the information governance, and it'll be reported. Now, there is probably you might say, well, why don't they try and get test the number right before they send the letter? Admin can, because they haven't got time. Right. So they'd rather send the paper letter than the other two options, which are get it wrong by sending it to the wrong patient, or phoning up the whatever numbers on there to check that they are the right numbers.
It's the least worst.
It's the least worst, exactly. So I think, so when we look at London Care Record, I think some of the barrier to use initially was that people didn't want to get it wrong around that patient consent thing, right? People get information governance is one of those things that is sort of this kind of mythical thing that a lot of people know is a problem but don't quite understand. Whereas now, because we've sorted out the data governance arrangements, the information sharing governance arrangements, direct care, doesn't have to be consent based, people can log straight in.
Brilliant.
And yes, we keep an eye on what people are accessing. So if you start to access inappropriate records, we will find out about that, and we will let you know that we know. But it's some of those little that grit, that friction in the system, where you just make people think, oh, I might do something wrong here. I'd rather not do it.
And I think there's three things there, right? There's friction in the system, staff or patient side reduces ROI and scale. And we should fight to reduce friction in the system whenever we can. I think that's one of the things that we've all learned from the project we've done together and over the time of working in digital health. The second one is information governance being an enabler. And I have to say a huge shout out to the IG community, because I think in the 15 years or so that this has been going on, we've gone from IG being viewed as a blocker in these sorts of projects to actually being a real enabler. And it's amazing how that community has embraced so much change over the last 15 years, I think. Very rarely, in fact, I'll go as far as to say never, do we in a rollout now have a information governance person saying that we can't do this. They have challenges around the specifics, and that's their job, and that's absolutely appropriate. But, things like that example of let's understand the pragmatic implication of this checkbox, and it's stopping the ROI, and then working together to remove it is absolutely massive. And I think is a huge credit actually to the whole system changing the way it thinks.